edition of ECMO Varna, and welcome to all our virtual attendees. I am here today to talk about mechanical complications on ECMO support. And I have nothing to disclose related to this topic. Main mechanical complications of ECMO support are pump failure, membrane lung failure, gas failure, circuit air embolism, circuit disruption, and accidental decannulation. Several of these complications are potentially life-threatening per se, or because could result in sudden lack of extracorporeal support, or complication management could require extracorporeal support to be interrupted. No matter the reason, lacking support to hemodynamics or gas exchange could induce hypotension, profound hypoxia, hypercarbia, and eventually cardiac arrest. Moreover, you have an increased thrombotic risk on the circuit due to the lack of flow. Every member of the ECMO team, meaning all healthcare professionals caring for patients on ECMO, needs to be aware of all of these potential complications, needs to be able to prevent these complications as feasible, and needs to be able to early detect problems at the bedside and be prepared to approach emergency scenarios. Pump failure is defined as the inability of the pump to generate and maintain a target blood flow. Extracorporeal blood flow is going to stop, even suddenly, resulting in lack of circulatory and respiratory support, and with the patient developing acute cardiac or pulmonary failure, or both, depending from ECMO configuration. Pump failure could be related to the lack of power as the battery becomes exhausted. Connect ECMO system to power every time it is feasible, check batteries are charging, and before any transport assess battery's autonomy. Pump failure could also be due to any drive or console malfunctioning not related to power supply. During the run, it is safe and advisable having a backup console always available and having a backup pump, whether manually or electronically driven, the latter for completely magnetically levitated blood pumps. And when you need to insert the pump pad in the backup pump or to change the drive unit, the return line needs to be clamped until blood flow could be resumed. This because centrifugal pumps are non-occlusive, and when a centrifugal pump stops, you risk a phenomenon named backflow, with blood from return cannula and return line reversely flowing through the system, contributing to hemodynamic derangement. So do not forget to clamp return line until the issue is detected and solved, and RPM could be increased again. Sometimes the problem is in the pump pad. Pump pad disengagement, which is the improper positioning of the pump pad in its housing. If pump pad is disengaged, it requires repositioning, again with return line clamp before removal from the pump. Pump pad thrombosis, impairing the flow, or massive presence of air within the pump pad, which deprives the pump and the pump stops. If pump pad is clotted or massive air is present, you may need to change the circuit emergently. When the issue is in the pump pad, signs of pump failure include the grinding noise and vibrations arising from the pump, particularly with disengagement and thrombosis, like in the example here. And if you slow down the video, you could see something in the pump pad, which is a clot. If air enters in the circuit, you could see air or microbubbles within the pump pad. Another sign in general of pump failure is unstable blood flow or abrupt stop of the flow with impaired hemodynamics on VA ECMO and profound hypoxia on VV ECMO, both potentially evolving to cardiac arrest if the patient is highly or completely ECMO dependent. So, pump failure is potentially associated to poor outcome, as you could see here in the data from the ELSO registry from 2016 to 2020, even if pump failure is not so frequently reported in the adult population. But when your blood flow stops, also exclude a failing flow sensor, meaning a flow sensor no more able to properly read blood flow, but with the pump properly running. Circuit pressures will be preserved and hemodynamics and gas exchange will not be impaired. This could happen during the run, particularly with all flow meters, but also with actual sensors if the clamp is left open. But sometimes you have an impaired blood flow or you do not have a blood flow at all, but the pump is not failing. Consider that centrifugal pumps are preload and afterload dependent, so a significant lack of preload, drainage failure, or an excessive resistance to pump output, return obstruction, will impair the flow even with a potentially perfectly working pump. Impaired venous drainage, the so-called drainage failure or drainage insufficiency or access insufficiency, is a condition occurring when there is a mismatch between the venous return to the drainage cannula and the degree of drainage pressure, which is the inlet pressure, the suction pressure at the set RPM, so at the set pump speed. When mismatch occurs, the venous vessel, often the inferior vena cava, collapses against the drainage cannula with occlusion of the drainage baskets and temporary loss of extracorporeal blood flow. This allows for venous pressure to rise and blood drainage restarts in few seconds. For this reason, when you have drainage failure, decreasing RPM like this and slowly re-increase sometimes improve this condition while trying to understand and fix what is going on. At the bedside, you can feel vibrations of the drainage tubing if you touch it, but when the drainage failure is significant, you can see a clear swinging movement of the drainage tubing, and this is referred to as kicking or chattering. If you look carefully in this video, you could see small vibrations of the drainage tubing, while in this other example, we have severe chattering with more intense movement and alarm activation, as drainage failure will impact on both the blood flow and inlet pressure. And we could see the impact on ECMO parameters in this other video. The temporary collapse of venous vessel generates an inconsistent, erratic blood flow, like in this case, and this persists until the issue is solved. This might impair ECMO support, and moreover, this reduction of blood flow increases the risk of circuit thrombosis. The inlet pressure becomes inconsistent, decrease, then increase, then decrease again, and if the inlet pressure becomes really negative, this might induce cavitation. Vibrations may also involve the drainage cannula, like in this case, and if this is what you could see at the bedside, this is maybe what is going on at the level of the inferior vena cava, so consider that drainage insufficiency might potentially induce vessel injury. Why drainage insufficiency happens? As said, it is due to a mismatch between the venous return and the demands in terms of pump speed. It is definitely not an easy mechanical complication, as it could be due to too low venous return or excessive pump speed, or a combination of this. So not only the circuit but the patient is involved. About venous return, it could be simply, between quotation marks, hypovolemia, which could be absolute as bleeding. Do not forget, patient on ECMO is usually on systemic anticoagulation, but hypovolemia may also be relative as vasodilation. Moreover, drainage insufficiency could be due to raised intrathoracic or intra-abdominal pressures, so you could have dynamic hyperinflation with auto-PIP, a Valsalva maneuver, cough or sedation issue with the patient fighting with the ventilator. Increasing intra-abdominal pressure due to intra-abdominal hypertension, again, maybe is bleeding, tension pneumothorax or cardiac tamponade. About pneumothorax, consider that it happens on ECMO and may get initially unnoticed, as extracorporeal life support might mask this complication until it is extensive or tense. Pneumothorax, these are the data from the ELSA registry for the adult population, is more frequent in patients on respiratory support. We have seen a lot of pneumothorax in COVID-19 patients, for example, whether due to barotrauma or lung frailty, and it is associated with high mortality. Apart from underlying condition and mechanical ventilation settings in respiratory failure, pneumothorax could be iatrogenic at cannulation or during central line placement. Not every pneumothorax requires a treatment on ECMO. We should not always drain it, because unnecessary chest tube insertion may harm the patient and might significantly increase the incidence of major bleeding. This is also true for pleural effusions. Upon development of pneumothorax, consider if it is impacting on cardiac and lung function and on ECMO function. If pneumothorax is not clinically impacting, closely monitor its evolution. On VV ECMO, consideration should be first given to reduce mechanical ventilation settings, increasing extracorporeal blood flow as needed and as feasible. If pneumothorax is worsening, or if tension pneumothorax occurs, undermining not only native lung function and native cardiac function, but also extracorporeal support, and chest tube insertion is supposed to improve oxygenation and hemodynamics, pneumothorax should be carefully treated. Consider that on ECMO, pneumothorax may not only lead to drainage failure, but also to return obstruction on VV ECMO. We are going to talk about this later on. So, moving back to drainage failure, tons of potential patient-related determinants of drainage insufficiency. You really need a differential diagnosis in this setting. Moreover, it could be a circuit complication, any issue in the drainage tubing as a kinking or a clot, an issue in the drainage cannula, misplacement, displacement, again a clot in the cannula or in the vessel. This is a post-contrast abdominal CT scan showing a thrombus surrounding a drainage ECMO catheter in the inferior vena cava, and here the ECMO drainage cannula on the left, and on the right the corresponding thrombus at the cannulation. And again, at the cannulation, a thrombus cast of the drainage cannula in the inferior vena cava. Be careful, as the presence of these clots and thrombi outside or inside the cannula may be really dangerous at the cannulation, as these could move to the right heart and to the pulmonary vessels. And here, a tubular thrombus from an ECMO cannula floating in the right atrium after the cannulation. But sometimes you do not have any clot, any thrombus, but maybe the cannula is just too small in terms of diameters for your needs. The Hagen-Poiseuille law describes the factor affecting the flow through a cylindrical tube for a laminar flow, and the radius is the most important factor determining flow. Given that flow is directly proportional by the fourth power of the radius, larger diameters are required to achieve the high extracorporeal blood flows required for ECMO support. A smaller diameter will result in higher pressure drop, so carefully check the vein before ECMO, if feasible, and properly choose cannula depending on venous size and depending on estimated needs in terms of blood flow. Ideally, keep drainage cannula pressure drop below 50 millimeters of mercury. Length is a key factor as well, with longer length associated with higher pressure drop. This graph shows the pressure flow relationship for an hypothetic drainage cannula. Manufacturers publish these pressure flow charts for different cannula sizes, usually both for different diameter and length, but consider that most of these are built evaluating flow of water, which is a really Newtonian fluid, and not evaluating blood flow. This study investigated blood flow through various ECMO cannulae. Independently from the cannula, the flow was lower at any given pressure gradient pumping blood compared with the charts presented by the manufacturers. A variable fractional additional pressure could be needed for blood compared with water. So the published chart does not correspond to clinical performance and may not provide the best guidance at the bedside. If drainage insufficiency is supposed to be related to drainage cannula size and you need a higher blood flow, maybe you need an upgrade to a double drainage configuration like veno-venous ECMO or veno-venous arterial ECMO. The two drainage limbs are connected through a Y connector before the centrifugal pump, like in this case here. We have a VVV ECMO with two drainage cannulae in the femoral vessels. Despite being a common issue during ECMO support, it is definitely not so easy to properly manage drainage insufficiency. Giving fluids, it's a really common reaction to drainage insufficiency on ECMO, but maybe these fluids are not needed and potentially harmful for both respiratory and cardiac failure patients. As said, start reducing pump speed, and if the problem persists, assess the patient, then assess the cannula and the circuit to understand why drainage failure is happening, and eventually assess fluid responsiveness before giving fluids, and eventually choose fluids according to the situation. For example, if the patient is bleeding, he deserves blood rather than salt water. A note on bleedings: as a consequence of both patient and circuit interaction, and as a consequence of underlying disease, of eventual procedures during the run, of eventual pre-existing comorbidities and evolving organ failures, hemorrhages are common in all patients on ECMO. Systemic anticoagulation to prevent thrombosis may be the trigger. Factor consumption, platelet consumption, or platelet dysfunction and fibrinolysis may worsen bleedings. These are the data from the ELSE registry, again in the adult population, 2016 to 2020. Most frequent bleedings are gastrointestinal bleedings, cannulation site bleedings, and surgical site bleedings for all indication, and cardiac tamponade 2 for cardiac indication. Persistent and severe bleeding may impact on drainage effectiveness, so on extracorporeal life support. Drainage failure and erratic blood flow could be the first signs of an internal bleeding on ECMO. We could have massive bleedings like the ones you could see here. Here, a mediastinal hematoma after chest compression related injury of the mammary artery, and here a giant hematoma in the right retroperitoneal renal space. Bleedings may require anticoagulation dosage to be reconsidered, with main or life-threatening bleedings requiring to stop anticoagulation at all. Reverse eventual coagulopathies, thromboelastography or thromboelastometry, if available, may guide blood products or antifibrinolytics administration. Address bleeding source, sometimes hemostatic dressings or topical antifibrinolytics or compression may be enough. Obviously, sometimes aggressive intervention as endovascular or surgical procedure will be required. Return obstruction is a complication occurring when extracorporeal blood flow is impaired due to an increased resistance to the pump outflow due to any obstacle distal to the pump. The obstruction may occur at the membrane lung level or may involve return tubing, return cannula, but could also depend on patient pathophysiology or recovering physiology. Which are the main potential determinants of return obstruction on ECMO could be the membrane lung, the tubing, the cannula, or the patient. About the membrane lung, an acute massive thrombosis. For return tubing, a kinking of the line or a clamp left on return tubing at ECMO initiation may be a compression of the line, such as the line under the leg of the patient during or after mobilization, or the line under the wheel of the ECMO cart. Line clotting and thrombosis may also potentially occur. For return cannula, displacement or misplacement may impair extracorporeal blood flow. Again, at ECMO initiation, a clamp left on the proximal end, or during the run, a clot or a thrombus inside or surrounding the cannula. About the patient, consider that on VV ECMO, the return cannula is inside the systemic venous environment, so increased systemic venous pressure, as with tension pneumothorax or cardiac tamponade, may lead to return obstruction. While on VA ECMO, the return cannula is in the systemic arterial circulation, so severe hypertension or aortic dissection may increase pump after load. If a complete obstruction occurs, extracorporeal blood flow is going to stop. With any obstruction occurring after the membrane lung, pre- and post-membrane lung pressures will severely increase, with the pressure drop across membrane lung approaching the zero. We have no flow, so ECMO will fail in supporting hemodynamics or gas exchange or both. Moreover, blood stagnation due to impaired extracorporeal blood flow may lead to intra-circuit thrombosis. If a partial or an erratic obstruction occurs, blood flow will decrease or become inconsistent. Also be aware of the hemolytic risk. Hemolysis happens on ECMO. In severe hemolysis, free hemoglobin concentration in plasma is above 0.5 grams per liter. These are the data from the ELSA registry, again referred to the other population, respiratory support, cardiac support, and ECPR. Free hemoglobin is nephrotoxic, pro-inflammatory, pro-oxidant, with hemolysis potentially associated with increased risk of renal failure and multi-organ failure. Hemolysis may occur as red blood cells are exposed to excessively negative pressures below 100-120 millimeters of mercury in the setting of drainage failure or too high pump speed, or if red blood cells are exposed to excessively positive pressure above 600 millimeters of mercury, for example due to too high flow or return obstruction. Another main determinant is the shear stress associated with turbulence, cavitation, and the presence of clots and thrombi in the circuit, which is another common mechanical complication on ECMO. During the run, the interaction between the blood and the non-biological surfaces of the extracorporeal circuit, even if surfaces are completely coated, may lead to a systemic inflammatory response, triggering the adhesion, the activation, and the consumption of procoagulant and anticoagulant factors and other blood components. Moreover, the shear stress, the turbulent flow, and non-physiological pressures may additionally activate and damage blood components. Underlying disease, comorbidities, and evolving liver and renal failure, as well as drugs impacting on coagulation and drugs impacting on metabolism of anticoagulant drugs, may play a role too in the development of hemostatic complication as bleeding and thrombocytosis and procoagulant states. And these are the data from the ELSA registry, again for the adult population, respiratory support, cardiac support, and ECPR. As you could see, thrombosis is common. Clots and thrombi formation within the circuit is one of the most common technical complications of ECMO support, despite the usual administration of systemic anticoagulation. Thrombosis is probably the main determinant of progressive or acute membran lung dysfunction or membran lung failure. Main functions of the membran lung or oxygenator are to transfer oxygen to the blood and to remove carbon dioxide from the blood. Inside the membran lung, we have layers of small diameters hollow fibers diversely arranged for transverse flow oxygenators or axial flow oxygenators. A healthy membran lung allows for gas exchange via diffusion through these fibers from the gas phase into the blood phase for oxygen and from the blood phase to the gas phase for carbon dioxide. Thrombotic, fibrin or cellular deposits on hollow fibers worsen gas exchange, impairing membran lung performance. Extensive clots and thrombi formation around fibers creates a ventilated but not perfused compartment inside the membran lung with a dead space effect, so with a ventilation-perfusion ratio approaching infinity. Pseudomembranous deposits on the wall of hollow fibers may completely prevent gas exchange with a shunt effect and ventilation perfusion approaching the zero. These conditions are characterized by worsening of membran lung efficiency, impairing both oxygen transfer and carbon dioxide removal. Measured gas transfer does not meet anymore the capacity of the device. Membran lung failure, resulting in decreased or completely absent extracorporeal support to gas exchange, is a potentially life-threatening ECMO complication requiring prompt detection and management. If membran lung is failing and the patient still requires ECLS, you may need to replace the device. How to decide if replacing membran lung or wait? Monitoring gas transfer efficiency is critical to understand membran lung performance and its eventual decrease over time due to an aging process or due to potential complications as thrombosis. The criteria for an elective membran lung or complete circuit exchange rely on the combination of both circuit and laboratory parameters, along with considerations relating with feasibility of weaning from extracorporeal support within a short time. Consider membran lung residual effectiveness in terms of gas exchange. You could sample pre- and post-membran lung blood gases to evaluate performance in terms of both carbon dioxide removal and oxygen transfer. Monitors providing a continuous measurement of blood parameters as pre- and post-membran lung oxygen saturation and parameters as sweep gas flow and carbon dioxide in exhaust gas leaving membran lung are available, also providing advanced data on membran lung contribution to total oxygen and carbon dioxide exchange. Other devices estimating membran lung effective blood volume and its change over time with reduction possibly linked to thrombosis also exist. Check circuit pressures and resistances. Thrombosis impairs blood flow through the membran lung, so membran pressure drop, the pressure gradient between the premembran pressure and the postmembran pressure is going to increase. Consider that pressure drop is affected by extracorporeal blood flow, so a more accurate parameter to be evaluated is the ratio between pressure drop and extracorporeal blood flow, with significant increase in this ratio suggested increasing internal resistances. And this is an example with increasing premembran lung pressure and decreasing postmembran lung pressure and increasing pressure drop. Visual control on the tubings could detect the lack of color difference between the blood entering and the blood exiting membran lung when you have a membran lung failure. With the so-called flashlight test, transilluminating the device, you could see fibrin strands, you could see clots and thrombi. More common locations of thrombi and clots usually depends on the flow dynamics of the specific device. Assess the extension and the location of this phenomenon. Consider that we are not able to explore with flashlight test the deeper structures. With devices integrating in a single block centrifugal pump and the membran lung, the venous side of the oxygenator is not feasible anymore. Also consider the eventual impact on blood cells with the increasing signs of hemolysis, no other evident explanation, and consider eventual impact on coagulation due to consumption coagulopathy with signs of disseminated intravascular coagulation and bleeding. Again, with no other evident explanation. Maybe you have a visible major clot, possibly evolving to an acute blood flow obstruction, or a clot in a dangerous location, meaning on arterial side of the oxygenator, proximal to membran lung outlet, with risk of acute return cannula thrombosis, systemic embolism on VA ECMO, or pulmonary embolism on VV. Also consider that you could also have acute drainage insufficiency if the clots move from the oxygenator to the return tubing and is re-aspirated from the drainage cannula. This the data from the ELSO registry. Membran lung failure is one of the most common mechanical complications on ECMO, occurring frequently, particularly during respiratory support, probably due to extended length of the runs and eventually due to lower blood flows. If your membran lung is definitely failing, you need to consider replacement. Consider also that not all available systems allow you for a selective oxygenator or in general for a selective replacement of any component. So in some settings, a whole circuit replacement may be required. Apart from thrombosis, condensation inside the hollow fibers, the gas compartment, due to temperature gradient between the gas and the blood, the so-called wet membrane may impair carbon dioxide removal. Increasing fresh gas flow to 10 to 15 liters per minute in the adult patient with polymethylpentane membranes for a few seconds may purge this water. We have a couple of examples here. Look at the gas outlet. You could see the water. And here we have another kind of membran lung. And again, we could purge the water, the condensation inside the gas compartment. The risk of plasma leakage, which is the leakage of plasma from the gas outlet of the oxygenator, is negligible with polymethylpentane membranes, the most widely used membranes for ECMO nowadays. This because polymethylpentane fibers have a nanoporous design. The risk of plasma leakage with previous generation polypropylene hollow fibers, which have a microporous design, is consistent. Consider that polypropylene membran lungs are still used in local circuits used in short-time ECLS as procedural ECMO or ASOR, extracorporeal interval support for organ retrieval in DCD donors. These circuits are also used sometimes for ECPR, at least at initiation, and during COVID-19 have been used in constrained research settings due to the lack of long-term circuits. So this potential complication still needs to be known and mentioned. Also consider that any issue within the gas line supplying fresh gas flow to a perfectly functioning membran lung could severely impact or completely compromise gas exchange. But let's move from gas to air. Circuit air embolism refers to the presence of air within the extracorporeal circuit, ranging from foam or little bubbles to a large quantity. The presence of air in the extracorporeal circuit is an emergency in any case, as air might be returned to the patient with the risk of pulmonary air embolism or systemic air embolism, depending from configuration. So you have risk of pulmonary air embolism on VV ECMO and systemic air embolism on VA ECMO. You have both for hybrid configuration. This obviously also depends on the eventual presence of a cardiac shunt. Moreover, a large bolus of air can deprime a portion of the circuit, particularly the pump head, with sudden interruption of extracorporeal blood flow, and this is called airlock phenomenon. How and why air can enter the circuit? Gaseous emboli may be produced by a phenomenon named cavitation, as blood is exposed to highly negative pressure, for example, as a consequence of drainage failure. When cavitation occurs, dissolved gases in the blood bubbles out of solution. Cavitation rarely occurs with non-occlusive centrifugal pumps. Otherwise, air could enter to the circuit from atmosphere, either directly from the circuit due to improper priming or connection, or due to a breach in the circuit, or from the patient, mostly from cannula and central venous line. Let's go into details. Air might be present in the circuit due to improper priming. Modern circuits are usually really quick and easy to be primed, but carefully check the system as residual bubbles may be trapped, particularly in the membran lung and in connectors. Air could enter at connection of the circuit to the cannulae at ECMO initiation on when you replace the circuit or when you replace a circuit component. To prevent this risk, all connections are usually performed with a technique named underwater seal. This is the strategy that you could see in this short video. During the run, any breakage, disconnection, or opening of connectors within the pre-pump side of the circuit, which is the negative pressure side from drainage cannula to the center of the pump head, will induce aspiration of atmospheric air. Consider avoiding any excess on the pre-pump side of the circuit, including avoiding connectors with side ports and avoiding any manipulation of the pre-pump side of the circuit during the run, if feasible. For the same reason, misplacement, displacement, or even partial displacement or rupture of the drainage cannula or accidental opening of a side port on the drainage cannula could induce air aspiration. Again, consider avoiding the use of connector with side ports on drainage cannulae. Moreover, air could enter with improper manipulation or improper management of central venous line during the run. We have a drainage cannula often inside the inferior vena cava in adults and a central venous line usually at superior vena cava right atrial junction. These two catheters could be close, even really close to each other, as in the example here on the left, and this particularly on VA ECMO, as on VA ECMO drainage cannula is usually higher compared to VV configuration. But also for VV ECMO, if you are performing VV with drainage cannula inside the jugular vein, so in superior vena cava, the two catheters could be really close. We have subatmospheric pressure at the drainage cannula side holes and at the tip hole of the drainage cannula, so be careful as you could aspirate air through the central venous line if any of the central venous line lumens is left open to atmospheric air. Consider using needle-free connectors during ECMO and using controlled diffusion system to administer fluids and medications. On the right, and this is a complication, the tip of a peripheral inserted central catheter has been able to slip into the inflow basket of a double lumen cannula, leading to a repeated air aspiration inside the circuit during the run. So in such a situation, air noticing the circuit, no other explanations, think to and check other venous catheter. Also, insertion of central lines during the run and other procedures such as percutaneous dilational tracheostomy can introduce air. Using Trendelenburg position, reducing extracorporeal blood flow if feasible and as feasible in high-risk moments to increase the pressure in vena cava and covering the side with wet swabs could reduce the risk. If feasible, reducing extracorporeal blood flow during central venous line placement could be a good idea, not only to reduce the risk of introducing air, but also to avoid aspirating guide wires inside the drainage cannula and inside the drainage tubing, like happened here. This complication has been repeatedly reported on ECMO support. Going back to the air embolism complication, these are the data from the latest international summary of the ELSA registry referred to the adult patient from 2016 to 2020. The presence of air within the circuit is rare, but it could be life-threatening. As you could see here, survival could be very low, particularly during circulatory support. Air can result in severe or fatal complication if large amount of air reaches systemic or pulmonary circulation, or due to the lack of extracorporeal support if an airlock occurs, or if extracorporeal blood flow is interrupted while trying to remove the air or replace the extracorporeal circuit. When air passes through the pump head, you could hear a distinctive noise. Otherwise, air presence may activate the bubble sensor alarms. Often in current system, we have bubble sensor on both drainage and return limbs of the circuit. Air embolism on the circuit is an emergency scenario. As air is noticed within the circuit, you need to understand the location of the air and the extension of the phenomenon, as both of these may impact on management. If you have a really small amount of air before the membrane lung, you could try to remove the air through aspiration without clamping return line and without interrupting blood flow, so without interrupting extracorporeal support, using a large 50-60 milliliters Luer lock syringe. You need to connect this syringe to the nearest Luer lock connector on the circuit, for example, a pre or post membrane lung stopcock. And you need to try to aspirate air. If you have a large amount of air in the circuit, or if air is located after the membrane lung too close to the patient, particularly on VA ECMO, this requires to immediately clamp the return line as close as feasible to the patient to prevent any introduction or to prevent any further introduction of air into the vascular system. Put the patient in Trendelenburg position on VA ECMO and call for help. After clamping the return line, you could try to remove the air from the circuit using gravity to facilitate the movement of air to the nearest stopcock, removing the pump pad or the membrane lung or both from their housings. No clamp needs to be placed on the drainage line to allow for air to be evacuated from the circuit. When air removal is unfeasible or unsuccessful, you may need to replace the whole circuit if extracorporeal life support is still needed. After complete de-airing or circuit replacement and after air source is detected and fixed, ECMO support may be resumed. Circuit disruption refers to the breaking continuity of the circuit during an ECMO run. This results in air embolism if occurring in the pre-pump side of the circuit with subatmospheric pressure inside, or resulting in massive blood loss if occurring in the post-pump side of the circuit with positive pressure inside. Why disruption may happen? Due to improper setup or improper manipulation of the circuit with accidental disconnection, inadvertent cut or puncturing, a rupture of a defective component, reckless movements of the patient, of the ECMO cart, or of the bed. Disruption should be approached with isolation and replacement of the involved component, if feasible, otherwise a circuit replacement may be required. If air entered in the circuit, this is an air in the circuit scenario to be managed accordingly. Isolation without interrupting blood flow could be attempted using tubing clamps or sterile gloves with point-like lesion or breaks involving an additional component as a pressure transducer, a sampling line, a renal replacement therapy, or hemofilter connected to the circuit. This could limit the blood flow interruption to the time strictly required to replace the involved component if a selective replacement of the involved component is feasible. Otherwise, a whole circuit replacement may be required. Accidental decannulation refers to the unintentional displacement of the cannula during an ECMO run. If the drainage cannula is involved, this could induce massive air entrance within the circuit. If the return cannula is involved, blood will be rapidly lost, leading to exsanguination with risk of hemorrhagic shock or cardiac arrest. With bicava dual-lumen catheter displacement, it is easier to have the first scenario due to exposure of proximal drainage baskets, but both situations may coexist, so air entrance and bleeding. Moreover, with any catheter, inadvertent decannulation results in sudden discontinuation of extracorporeal support and extensive bleeding from the insertion site. This risk is increased with an arterial return cannula. Accidental decannulation could happen due to improperly secured cannula or tubing, with spontaneous movements of the patient, with reckless mobilization, with an unbraked ECMO cart or an unbraked bed, so it is preventable. Be careful. This is an example of drainage holders which may be used to support and stabilize tubing. Transparent film dressings to cover the insertion site allow for cannula fixation, for visual inspection of the access site, and for accurate monitoring of the depth of insertion of the cannula. These dressings also allow for prompt detection of bleeding and displacement. Bleeding from the insertion site may be an early sign of partial decannulation. When you need to replace these dressings, avoid improper tension on the cannula. Accidental decannulation represents an extreme emergency. You need to immediately clamp the return line to interrupt blood flow or to stop air entrance and blood loss, depending from the configuration. Compress the site to stop additional bleeding and call for help to provide support to the patient. Sometimes this is referred to as the 3C: clamp, compress, and call for help. Be careful, if the cannula, both for return and drainage cannula, is still partially in the vessel, blood loss will persist, and eventually for venous cannula, air entrance may occur if venous pressure is really low, particularly for jugular cannula if the patient is in sitting position. Do not attempt blind reintroduction. Provide the patient respiratory or cardiac support or both, depending from configuration and from dependency on extracorporeal support, and as needed, replace blood loss. If the patient still requires ECMO, you need to replace the cannula and you probably need a new circuit to be primed in order to resume ECLS. After stabilization of the patient, assess previously cannulated vessel for any injury and eventually perform repair as needed. Accidental decannulation is one of the complications requiring immediate extracorporeal support interruption with urgent need to isolate the patient from the circuit. Other complications which may eventually lead to the same circumstance are massive air embolism or acute thrombosis, a breach on the circuit, and console failure. It does not happen often, so the ECMO team needs to practice to be ready coming off ECMO emergently. And this is the schematics of a basic ECMO circuit: a drainage cannula, a drainage tubing, a centrifugal pump, a membrane lung, and a return tubing, and a return cannula. And this is the direction of the flow. If you need to emergently stop blood flow with the centrifugal pump in use, you just need to clamp the return tubing. Pump after load will suddenly rise and the flow will decrease to zero. If you have time, you could also clamp the drainage line and decrease RPM to zero and decrease fresh gas flow to zero, but all of these are not strictly required. To be prepared and safe, having 4 tubing clamps always available on the ECMO cart, 2 for clamping the drainage and return tubings, 2 for isolate any component or the whole circuit for replacement is advisable. As the issue is solved and eventually as a new circuit is connected, unclamp the drainage line, resume RPM, and when above 1000, 1200, unclamp the return line. Adjust blood flow and carefully increase gas flow. On veno arterial venous ECMO, VAV or hybrid configuration, if you need to emergently stop blood flow, you need to clamp return tubing before the Y connector to completely interrupt the flow. Or if you just clamp one of the returning limbs, you will redirect all the flow to the unclamped return line. Otherwise, you need to clamp both venous and arterial limb, but the latter intervention requires longer time. This unless you need to selectively isolate one limb, for example, as you have a complication just involving one of the returning lines. For VAV ECMO, consider having 5 clamps always available on the ECMO cart, just in case. So, to summarize, if you need coming off ECMO emergently, identify ongoing complication, clamp return line, call for help, provide respiratory support, maximizing mechanical ventilation settings or cardiac support with inotropes and vasopressors, or provide both as needed depending from configuration and patient dependency on ECMO. If a cardiac arrest occurs, provide ACLS as needed. If you do not have ECLS anymore, patient developing cardiac arrest will require conventional cardiopulmonary resuscitation. Identify if you should go back on ECMO in the selected patient, so no winnable, no futility, address underlying problem and restart ECMO support. In conclusion, just a note on cardiac arrest on ECMO support. This is a bit off topic because cardiac arrest is not a mechanical complication, even if cardiac arrest may occur as a consequence of mechanical complication on ECMO. Do we need to provide a cardiopulmonary resuscitation, conventional cardiopulmonary resuscitation to every patient on ECMO developing cardiac arrest? No. First thing you need to consider is the configuration of extracorporeal life support, because on VV ECMO, cardiac arrest is associated with complete loss of cardiac output, so cardiopulmonary resuscitation is needed. While on VA configuration, extracorporeal support is a circulatory support with the pump, if working, theoretically providing systemic perfusion. If you have a flow, mean arterial pressure will be preserved. Be sure that it is a full extracorporeal blood flow, for example 4 to 5 liters in the adult patients, as otherwise higher flow could be needed to provide proper perfusion. If you do not have a flow anymore, also on VA ECMO, you may need CPR. These are the data from the ELSA registry for respiratory cardiac support and eCPR. Overall, 3.7% of the adult patients on ECMO may require CPR during the run. If your patient on ECMO develops a cardiac arrest, the first thing you need to consider is the configuration of extracorporeal support, VV ECMO or VA ECMO. On VV ECMO, you need to immediately provide conventional CPR. Also consider, if cardiac arrest is refractory, to switch to eCPR, so to VA ECMO, if no main contraindication exists in persisting with life support as futility. On VA ECMO, you need to consider your blood flow. Is the extracorporeal blood flow is preserved or not? If the extracorporeal blood flow is preserved, you need to assess if it is a full blood flow or a partial blood flow. If it is a partial blood flow, you need to increase to achieve a full blood flow. If you do not have blood flow anymore, or if you are not able to increase your partial blood flow, you need to consider conventional CPR. Also consider that on ECMO, cardiac arrest may be a consequence of a circuit complication as pump failure, return obstruction, or drainage failure. About conventional CPR, if CPR is needed, be sure that you do not have a central pulse anymore. Check if rhythm is shockable or not, and eventually provide a shock. Be careful with adrenaline administration to avoid hypertensive peaks and bleeding risk with return of circulation, and eventually decrease pump flow to achieve a better venous return. In the meanwhile, consider potentially reversible causes of cardiac arrest because some of the causes are potentially ECMO related. You could have bleeding related hypovolemia, for example, due to systemic anticoagulation, hypothermia, due to any malfunctioning of the ether unit with fast loss of it, hypoxemia due to acute membrane lung failure or gas failure. On VA ECMO, you also need to evaluate for the occurrence of differential oxygenation in the setting of dual circulation. Tension pneumothorax, particularly for respiratory support, as previously said. Cardiac tamponade, eventually as a complication of cannulation procedure. Consider that tamponade happens during the run. Incidence is up to 3 to 4%, particularly for cardiac support, but diagnosing tamponade could be tricky on ECMO because of circulatory support and because of the reduced venous return. And also consider that you could have eventual thrombosis, both massive pulmonary embolism or coronary thrombosis. Do not forget, on VA ECMO, a left ventricular and aortic root thrombosis extending to the coronary arteries have been reported as a result of blood stasis with severely impaired native lung function. Left ventricular thrombosis could also occur as a consequence of prolonged cardiac arrest with loss of native cardiac output on VA ECMO. Cardiac sonography, particularly transesophageal echocardiography and lung ultrasound, could guide resuscitation and help with differential diagnosis. The basis of a good ECMO run is preventing complications or preventing the impact of eventual complications. Be aware of all of these to remain suspicious. Be prepared to manage and train as a team repeatedly. The less the number of ECMO patients you manage at the bedside, the more you need to train with hands-on labs and simulation. Carefully and continuously monitor both the patient and the circuit to promptly detect and treat any issue. Minimize circuit manipulations before and during the run, and minimize procedures and transport during the run as feasible. Preventing mechanical complications is definitely better. And here my Twitter handle for any comment or question.